Let's go across to table 5 and then moving on to the case for regulating healthcare assistants. We've had a bit of a discussion about this already. What did you conclude?
Okay, to regulate or not to regulate, that is the question. I think what we did need to, we considered as a group, first of all, was that we needed to improve public confidence and meet public expectations and the expectations of families and patients, who I think it's very clear to say, given the CQC report and mid-staffs, who need assurance from us as healthcare leaders. And overwhelmingly, I have to say, Jill accrued a majority vote on this table, as it was felt collectively that we felt that regulation would actually blur accountability. And what we actually needed from a practical approach was a standardised programme of training and competency that was transferable across organisations, and that would give the level of assurance both to organisations and patients and families. And within that would be behavioural competencies that would be integral to improving care and compassion, as they are a substantial part of our workforce. And that actually all organisations should now be actively using behavioural interviewing techniques in order to triage out members of staff or potential members of staff who are unlikely to be suited to healthcare. And actually we should be working with our managerial levels to actually, and managerial training to support that. So that was our thought, and so Jill got the majority vote on this table for not having regulation.
Just to be clear, because there's some aspects of what you're saying that are more regulated than now. So the bit that you wouldn't like to see is healthcare assistants registered.
That's
is
correct,
that right?
and we would be promoting standardisation, national standardisation. And then we did ask a question, whatever happened to skills for health? Because isn't that what we did the first time round, possibly the second time round?
With competencies.
Yes.
But then what happens about tracking people from one organisation to another? So one bad apple rolls up in one trust, there's no mechanism of tracking whether they can just get re-employed somewhere else or indeed in an agency situation.
Well, some of that comes from behavioural competency interviewing, because actually Em has got a particular, can I hand over to you actually, because it might be worth talking about behavioural competency in interviewing and what your experience at RD&E.
You hate it when someone does that to you.
Yeah.
We were just talking about, we've just put some clinical apprentices in, and we did behavioural scenarios with them in terms of the selection process. It was very clear, probably a 50% deliberate attrition at that first stage, that people couldn't articulate how they would respond in certain situations, and therefore it was that element of sort of sifting out people that weren't suitable. But I don't know if that really answers your question about how do you stop the bad apple rolling around the system. But in some respects, I'm not sure that registration does either.
Okay, thank you. Any different views that people would like to share?
I think I partly agree in terms of what you said, but I think what you described in terms of induction and core competencies as sort of like stage one, they're a stepping stone towards regulation. I think in terms of your point about bad apple, I mean obviously if somebody were dismissed or left during an investigation or an inquiry that was about patient safety, then there's always the opportunity for the organisation to refer them currently to the vetting and barring scheme. But I think fundamentally we've been tackling this issue, or trying to tackle it unsuccessfully for the last 15 years. And I think certainly if we're going to engage in the workforce that we're talking about, which are healthcare assistants and healthcare support workers, then one of the things we've been very passionate about is making sure that we're listening to what they want and not just dictating what we think should be the case. And we have conference after conference of healthcare assistants talking about this issue, and there is no other solution that they've been able to come up with to crack the nut of the postcode lottery of what they do and where they do, other than moving towards some form of regulation. That said, I don't think that's going to happen overnight, and I think the points that you made about induction and competencies because they are part of a process towards it, are certainly where we should be starting, and I certainly think we should be doing that as a matter of urgency to make sure there's some level of consistency. So I very much respect the points that you're saying, but I think from the voice of healthcare assistants, which is one of the roles that we represent and that we speak for, they would very much welcome regulation.
Okay. If that were to, you've suggested that there should be some competencies and maybe some harmonisation of job descriptions. Which organisation would be best placed to lead that work? Can't be the NMC because they're not registered with them. So who would it be? Yeah.
I think one of the things that I'd like to see is NHS Employers as an organisation collates good work, Skills for Health collates good work in terms of what takes place. We've had some fantastic examples of good things that are currently taking place in organisations, and perhaps one of the starting points should be to gather that information and to see what level of consistency there is around induction and competency, and to design that system. But very much we would want healthcare assistants to be involved in that process and to be able to articulate and to give their views. Nurses don't want others dictating to nurses, doctors don't want others dictating to doctors. I think it's very much about making sure that we engage with people. Healthcare assistants are providing, along with nursing staff, the fundamentals of care, and patients are on the receiving end of those fundamentals of care. But ultimately, I think we have a duty of care to patients so that they are absolutely abundantly clear about who is caring for them and whether they are competent. And unless we have a level playing field around standards, patients aren't going to be equipped, and if they're not equipped, they can't even be advocates for themselves in terms of Nara's point earlier on around almost being able to regulate yourself by asking those probing questions. If patients don't know, they can't do that.